Well, next, our next speaker, I don't think needs almost any introduction, but I'm going to anyway. So I want to welcome Dr. Clair Francomano. And yeah, um, Dr. Francomano is professor of medical and molecular genetics at Indiana University. She's a leading authority in the United States on the Ehlers-Danlos Syndrome. I think there's no question about that. And her career has been including leadership at at the level of the NIH, with landmark 20-year study in the natural history of EDS. Dr. Francomano is globally recognized as an expert in connective tissue disorders. She has published extensively. If you don't see her name, go find another article because you're not reading a good one. And she continues to shape research and clinical care in this field. So let's welcome Dr.
Thank you so much. And thanks to Dr. Knight and the organizers here for welcoming me to here today. Thanks to all of you for being here. Well, that was a kind of hard act to follow. I'm going to talk about the genetically defined types of EDS today. There are 13 types of Ehlers-Danlos syndrome, and even though probably 90% of the patients who come through the door have what we currently call hypermobile Ehlers-Danlos syndrome or hypermobility spectrum disorder, those other 12 types are very, very important because part of the diagnostic criteria in thinking about hypermobile Ehlers-Danlos syndrome is that we have excluded all the other types of Ehlers-Danlos syndrome and the other hereditary disorders of connective tissue that present with hypermobility. So I'm going to see if this will work for me. There we go. These are my disclosures, but none of them are relevant to what I'm talking about today. So my objectives for the next half hour is to talk about understanding the major genetically defined subtypes and primary gene defects, recognize the hallmarks and clinical imaging features for the differential diagnosis, and appreciate the inheritance patterns and implications for genetic testing and counseling. So in connection with the Ehlers-Danlos Society and my colleagues who are involved in the work of taking care of people with hereditary connective tissue disorders, we've undergone a very large literature review looking at what is Ehlers-Danlos syndrome. And you've heard all this already today. It's a heterogeneous group of hereditary connective tissue disorders characterized with the joint hypermobility, skin hyperextensibility, and tissue fragility as the major hallmarks. And the mechanisms underlying these conditions are in collagen synthesis, processing, and structure, and other molecules that are involved in extracellular matrix integrity. And the classification that we're using today was published in 2017 in the American Journal of Medical Genetics, and it grew out of a symposium that was held in New York in 2016. It was the first meeting of the International Consortium on the Ehlers-Danlos Syndromes and hypermobility spectrum disorders. And all of the articles that were published in this 2017 publication in the American Journal are available on the Ehlers-Danlos Society website. And they have been used extensively over the last 9 years. They've been some of the most highly cited articles from the American Journal of Medical Genetics. So these are the genetically defined types of Ehlers-Danlos syndrome, the 12 genetically defined types. And I'm going to talk about each one of them in turn. I love this representation of them, which was done by Joanna Amberger and her colleagues at Johns Hopkins in 2018, just with the petals of each flower representing the different types of Ehlers-Danlos syndrome. And in 2018, I really wasn't thinking that we'd be sitting here in 2026 with that unknown word in the petal for hypermobile Ehlers-Danlos syndrome, but here we still are. So I think it's just so exciting what the science is leading us to, and I think you've already heard this morning some very, very compelling evidence that we're starting to understand better the biology that underlies this really complex condition. But these other ones, we've got a really good idea. And we have genetic tests, and we want to make sure that the patients who walk through the door with those rarer types are recognized when they present. So the classic type of Ehlers-Danlos syndrome is probably the most common of the genetically defined types. It's caused by pathogenic variants in the two genes that encode type 5 collagen. It's inherited as an autosomal dominant disorder. The major criteria are extreme skin hyperextensibility and atrophic scarring and generalized joint hypermobility. There's a long list of minor criteria. Now, in the interest of time today, I am not going to read all the minor criteria for each of these 12 types of EDS, but they're there. The slides will be available to you, and so you will have them if you wish. To make a clinical diagnosis, we need to have major criterion 1, which is the extreme skin hyperextensibility and atrophic scarring, and major criteria 2, or the skin involvement with extensibility and atrophic scarring, and 3 or more of the minor criteria. The recommendation is for any of these genetically defined types, if there is a okay. They have generalized skin hyperextensibility, hypermobility, and very, very easy bruisability and spontaneous bruising. So all 3 major criteria should be present to make a clinical diagnosis. And the big difference with this one is we want a family history compatible with autosomal recessive inheritance, because the classic-like type of EDS is caused by pathogenic variants in the gene called TNXB, and it is inherited as an autosomal recessive. Now, the vascular type of Ehlers-Danlos syndrome is probably next up in terms of the prevalence, just behind the classic type. And this one is probably in the range of between 1 in 3,000 and 1 in 5,000. The classic type more in the 1 in 3,000 range based on published literature right now. Vascular EDS is caused by pathogenic variants in COL3A1 and is inherited as an autosomal dominant. The major criteria are a family history of vascular EDS with a documented causative variant in COL3A1, arterial rupture at a young age, spontaneous rupture of the sigmoid colon in the absence of known diverticular disease or other bowel pathology, uterine rupture, and carotid cavernous sinus fistulas. These are the minor criteria. Now, in 2017, when these papers were published, the people who wrote about vascular Ehlers-Danlos syndrome were outliers. They declined to say that we could make a clinical diagnosis with this number of major criteria and this one minor criteria. And they just said we should consider genetic testing in the presence of any of the major criteria, or if a person has several minor criteria, especially if they're less than 40 years old. So in other words, if you're thinking about, I wonder if this patient might have vascular EDS, you need to do the testing. Now, the kyphoscoliotic form of Ehlers-Danlos syndrome starts to get us into these ultra-rare forms of Ehlers-Danlos syndrome. The major criteria for this one are congenital muscle hypotonia and congenital or early onset kyphoscoliosis. So this is a curvature of the spine that's both forward and back and side to side. And then in addition, there's generalized joint hypermobility with dislocations and subluxations, particularly involving the shoulders, hips, and knees. Kyphoscoliotic EDS is caused by pathogenic variants in the PLOD1 gene and the FKBP14. The PLOD1 was the first one to be recognized. That's a gene that encodes the enzyme lysyl hydroxylase. And the lysyl hydroxylase plays a really important role in collagen metabolism. So to make a clinical diagnosis for kyphoscoliotic Ehlers-Danlos syndrome, you need either all three major criteria or the first major criteria, which is the congenital muscle hypotonia, plus, and the second one, the congenital kyphoscoliosis, and three or more minor criteria. But here again, we want to do testing if we suspect it. The arthrochalasia type is caused by genes encoding type 1 collagen. So these are called 1A1 and called 1A2, inherited as an autosomal dominant. And here the major criteria are congenital bilateral hip dislocations. They have severe generalized joint hypermobility and instability with multiple dislocations and subluxations and skin that is unusually stretchy. And for this one, the major criteria 1 and 3 are necessary to make a clinical diagnosis, or major criteria 1 and 2, and at least 2 minor criteria. Now, I should say that these are all clinical diagnostic criteria that are based on kind of consensus of experts. There's very little in the way of scientific support behind these clinical criteria. And so it's really, I think it's just very, very important, the work that's being done now with the mouse models and the work that this Road to 2026 committee of the Ehlers-Danlos Society is doing to try to bring more of the science into supporting some of these diagnostic criteria. But these are what we have right now. So the dermatosparaxis type, we have a long list of major criteria here. The major thing about the dermatosparaxis type is the skin fragility. And this really is very striking. If a patient comes in to see you and they have extreme skin fragility with congenital or postnatal skin tears, that is really, it's important to think about the dermatosparaxis type. There are characteristic craniofacial features, and the skin is redundant. It almost looks like cutis laxa. It has excessive skin folds at the wrists and the ankles. And when you look at the palms, there's excessive wrinkling on the palms. They also have severe bruisability, and sometimes there'll be hematomas that develop under the skin with minimal trauma. You may see umbilical hernias. There's postnatal growth retardation. So in general, these folks will be shorter than average, and they have short limbs and hands and feet. And they're there are quite a few perinatal complications due to connective tissue fragility. So for this one, the clinical diagnostic criteria include the major criteria 1 and 2, and at least one other major criterion, or 1 and 2 of the major criteria, and at least 3 minor criteria. The spondylodysplastic type, there are 3 genes. This is like alphabet soup to me. It's just, I find them very difficult to remember. B4 GALT7, B3 GALT6, and the SLC 39A13. Okay. These are all genes that are involved in the production of proteoglycans, which, like the collagens, are important structural proteins in the connective tissue. And all 3 genes require 2 copies, so it's an autosomal recessive condition, regardless of which of the 3 genes is causing it. The major criteria are the progressive short stature in childhood, hypotonia, which may be congenital or it may be relatively mild and of later onset, and then there is some bowing of the limbs. So for a clinical diagnosis to be made, we want major criterion 1 and 2, and the characteristic radiographic abnormalities, and at least 2 other minor criteria. Now, with the spondylodysplastic type, there are some gene-specific minor criteria. So the general minor criteria are listed on this slide, and then the next slide shows you the gene-specific minor criteria. And the important ones to remember are that the B4 GALT7 has some ocular involvement. The B3 GALT6 may present with ascending aortic aneurysm. So this gets you into the, like when you're thinking about the aortopathies, and they have club foot as well in B3 GALT6. And then in the SLC 39A13, there's a kind of a characteristic of facial appearance with prominent eyes, blue sclerae, and those finely wrinkled palms of the hands. So we're starting to understand that these are kind of distinct phenotypes based on the underlying gene for the spondylodysplastic type of EDS. The musculocontractural type may be caused by 2 different genes, CHST14 and DSE. And here again, this is an autosomal recessive condition. The major criteria are the multiple congenital contractures. And characteristically, they're contractures of adduction and flexion, and the presence of club foot. So there are characteristic craniofacial features which are evident at birth or in early infancy, and then the skin involvement with stretchy skin, easy bruising, skin fragility with atrophic scars. And here again, we may see the increased palmar wrinkling. So at birth or early childhood, we want to look for major criteria 1 and 2. If we're thinking about this diagnosis in adolescents or adults, we look for 1 and 3, the cutaneous features and the multiple contractures. The myopathic type is caused by pathogenic variants in COL12A1. And this is the only one of the 13 types of Ehlers-Danlos syndrome that can be inherited as either autosomal dominant or autosomal recessive. And here the presentation in infancy is congenital muscle hypotonia. and or muscle atrophy that it tends to improve actually with age. So it's worse when the babies are born. They have proximal joint contractures involving the knees, hips, and elbows, and hypermobility of the distal joints in the hands. Thank you so much. So to make a clinical diagnosis of the myopathic type of Ehlers-Danlos syndrome, you want to see major criterion 1 and at least one other major criterion, or major criterion 1 and at least 3 of the minor criteria. Now, you heard a little bit about the periodontal type of Ehlers-Danlos syndrome from Dr. Maitland earlier. The genes that encode this condition are C1s and C1r, which are elements of the complement pathway. The periodontal type is inherited as an autosomal dominant condition. And the severe and intractable periodontitis of early onset is the hallmark of this condition. When you look at the gingiva, they're not attached to the teeth well, and often patients will say they lost all their teeth before they were 30. So whenever I hear that story, immediately we're going to gene testing, you know. There's some skin findings that are typical of the periodontal type, these pretibial plaques that you can see on the upper right-hand side of the slide. And then the other major criterion is the family history of a first-degree relative who meets the clinical diagnostic criteria for periodontal EDS. So to make a clinical diagnosis here, we want to see the major criterion 1 and 2 other major criteria and 1 minor criterion, or major criterion 2 and 2 other major criteria and 1 minor criterion. All right. Now, the brittle cornea syndrome is the only one of these types of Ehlers-Danlos syndrome that it isn't called Ehlers-Danlos syndrome. It is the major presentation is really in the ocular globe. The cornea is very thin, and it may or may not rupture. So sometimes the cornea actually fracture. And it can lead to blindness. They have early onset of progressive either keratoconus or keratoglobus. When I was preparing this talk, I had to look up what is the difference between keratoconus and keratoglobus. In keratoconus, the cornea kind of comes out and it makes a cone in the front of the eyeball because of the thin nature of that cornea. And in keratoglobus, the whole cornea is kind of enlarged. It's a more global involvement of the cornea than it is with keratoconus. And then we also see blue sclerae in this type of brittle cornea syndrome. You can see on the minor criteria, a lot of these continue in the ocular phenotype, but there are skeletal aspects to the phenotype as well. So there may be developmental dysplasia of the hip, hypotonia, scoliosis, long thin fingers or arachnodactyly, and hypermobility of the distal joints. So the skeletal system is involved, but really the focus is on the eyes in this condition. For the cardiac valvular type, the gene is called 1A2. Inheritance is autosomal recessive. These people with this condition have a very severe progressive involvement of the cardiac valves. They may be usually the aortic valve or the mitral valve. And the skin involvement is skin hyperextensibility with atrophic scarring, thin skin, and easy bruising. They have joint hypermobility, which may be generalized or it may just be restricted to the small joints. And to make a clinical diagnosis, we either want major criterion 1, which is the progressive cardiac valvular syndromes, and a family history compatible with autosomal recessive inheritance, and at least one other major criterion or major criterion 1 and a family history compatible with autosomal recessive inheritance, and at least 2 minor criteria. So that's a quick rundown through all those types of Ehlers-Danlos syndrome. Dr. Alan Hakim has come up with what I think is a truly brilliant mnemonic to remember the things that we have to think about when we're thinking about, are we going to test? And he used the word focused. So I'm going to just run through these very quickly. Family history, organs or internal problems, cardiovascular issues, unexplained sudden death, skeletal abnormalities, skin abnormalities, eye abnormalities, and dental. So for the family history, if there is a family history of a pathogenic genetic variant and confirmed diagnosis of another type of Ehlers-Danlos syndrome or another hereditary disorder of connective tissue, we want to be thinking along those lines in the differential diagnosis of our patient. If there's a personal or family history of recurrent pneumothorax, that might be pointing us to the vascular type of Ehlers-Danlos syndrome or to Marfan syndrome. So, and if there are unexplained tears or ruptures of the heart, such as bowel or uterus, we should be thinking about the vascular type of EDS. The cardiovascular issues, dilated aorta, large arteries, arterial dissections or unexplained severe bleeding. The carotid cavernous fistula is common in the vascular type, any kind of thoracic aortic pathology. These all should be pointing us to genetic testing. If there's a family history of unexplained sudden death at age less than 50 years, we have to think it could have been caused by a vascular problem or organ rupture. So that points us towards testing. The skeletal abnormalities that should raise red flags in your mind: clubfoot, congenital hip dysplasia, joint contractures, the severe kyphoscoliosis, severe pectus carinatum or excavatum, unexplained low trauma fractures, short stature, or mallet finger. Any of these would be more suspicious for a type of Ehlers-Danlos syndrome other than the hypermobile type or hypermobility spectrum disorders. The skin findings that would point us in that direction are extreme hyperextensibility, extreme scarring of the shins with hemosiderotic scars, which is what we typically see in the classic type of EDS, bilateral varicose veins of early onset. A prematurely aged appearance is something that we see sometimes in the vascular type of EDS, and recurrent hernias of the abdominal wall or the groin. The eye abnormalities include lens subluxation or dislocation. That should make us think about Marfan syndrome. Retinal detachments, we think about Stickler syndrome. Vitreal changes and corneal scarring. All of those should point to some other hereditary disorder of connective tissue or other type of EDS than hypermobile. And then the dental abnormalities are the severe periodontal disease and loss of teeth at less than 40 years, and dentinogenesis imperfecta or malformation of the dental enamel. So the presence of any of those focused red flags on the personal or family history should really make us think about doing genetic testing to look for one of the genetically defined types or other hereditary disorders of connective tissue. Thanks very much for your attention.
That was wonderful. All right. Any questions for Dr. Francomano? Yes.
Well, I think if you can make the argument that, oh, the question is, how can we convince the insurance companies to pay for the genetic testing if we're going on clinical diagnoses? The, you can make the argument that there is the presence of in the personal or family history or on the physical exam, there is a finding or there are findings that are suggestive of a condition that can be diagnosed molecularly. So there you have a reasonable suspicion that there may be a molecularly diagnosed condition in front of you. And we usually don't have a problem getting insurance to pay for the hereditary disorders of connective tissue panel, which is we can do with either Invitae or GeneDx.
Abby.
Yeah, as someone of rare type, there's two kind of questions, I guess, that come forward among the rare type community that we often chat about. One being self-diagnosis of a rare type based on a variant of uncertain significance, and then the other being not having a positive pathogenic variant in your genetic test, but still receiving a clinical diagnosis of one of the monogenic types of EDS. Are those things that you could speak on?
So the question is first about variants of uncertain significance, and the second is, can we make a diagnosis, a clinical diagnosis, in the absence of a pathogenic variant? And so the variants of uncertain significance they're really a big challenge for us as geneticists, because when we get a variant of uncertain significance, it basically says to us that we just don't have enough information about that variant to say whether it could be causing the presentation of the patient in front of us or not. And there are some things that we can do to try to clarify that. Sometimes we can do family studies. If there are multiple people in the family with the same clinical presentation, we can see if that variant travels in the family and is it co-inherited with the phenotype. So if say the person has this hereditary connective tissue disorder, they've clearly inherited it from their mother, and they've inherited that variant of uncertain significance from their father, then it's probably not going to be the causative gene for them. As you heard from Dr. Russell, we don't know a lot still about the genome and about the genes that cause these conditions and about the variants that cause these conditions. So it's very possible that a person can present and meet the clinical criteria for one of these rarer types, but that we will not find a pathogenic variant in the gene for that condition. And that may be because the variant is in a regulatory region of the gene, or it's in deep inside one of the introns, or it's in a place that affects the splicing of the RNA after the RNA is transcribed from the gene. So we just have to be humble about this, because there's really so much we still don't know. So if a person, they talk about it looks like a duck, walks like a duck, quacks like a duck, it's probably a duck, right? And same thing for the rare types. If they meet a lot of the criteria and they meet those diagnostic criteria for a rare type, I certainly will make that diagnosis, even if the gene testing comes back negative.